Thank you, Dr. Masur, and good morning. I'm just going to move right along here. I hope that there are no slide mess-ups, and I say that because I submitted mine on time and they were perfect, but when I just reviewed them on the equipment here, a couple of them weren't. So the AV crew's been very helpful, and I hope they all work out. So, malnutrition in hospitalized patients, it's a significant problem. I've defined it here as a disorder in body composition reflected in decreased body mass, which in turn is associated with decreased organ mass and ultimately with decreased organ function. Now, obviously, there are lots of different kinds of malnutrition. Protein-calorie malnutrition, obviously the most common healthcare problem in the world. But we can also have malnutrition as a result of a specific nutrient deficiency or as a result of altered metabolism resulting from a disease process. It's going to be that latter form of malnutrition that we'll emphasize here today. Now, the incidence thought to be 25 to 50% on admission even to American hospitals and probably develops in an additional 25 to 30% of patients during their hospitalization. Morbidity is thought to be in the range of 25%, primarily wound and infectious complications, with a mortality of perhaps 5%. Now, obviously, this is difficult to prove simply because in the United States, people don't get admitted to hospitals just for malnutrition. They get admitted for trauma or for sepsis or for cancer or whatever. And so malnutrition tends to be a comorbid feature in their outcomes. The thing that I really want to emphasize here today is the concept of starvation versus stress hypermetabolism. It's this latter problem that many of our ICU patients have. Now, you're all familiar with starvation. It's a clinical situation that develops whenever nutrient supply is inadequate to meet nutrient demand. It's characterized by a specific metabolic adaptive response that's aimed at preserving the lean body mass. And this response, of course, is characterized by decreased energy expenditure. These patients don't do very much. They sleep. They don't do their physical therapy. Utilization of alternative fuel sources, which I'll discuss in just a minute, and reduced protein wasting. Now, this metabolic adaptation to starvation, the initial fuel sources when we don't eat are glycogen, which of course is consumed within about 24 hours, followed by glucose, which is synthesized from amino acids via gluconeogenesis, and that glucose becomes the primary fuel source for the next 3 to 5 days. Only in the fully adapted starved state that occurs at about 5 to 7 days after one quits eating, fatty acids, ketones, and glycerol become the primary fuel sources in all but the obligate glucose-using tissues. The obligate glucose-using tissues, of course, are brain and red blood cells. Patients that are starving have a respiratory quotient of 0.6 to 0.7, reflecting utilization of fat as their primary fuel source. But ultimately, these patients have decreased net protein catabolism and ureagenesis during the fully adapted starved state, at least as compared to the fed state. So this starvation response then designed to protect the lean body mass. Now, stress hypermetabolism is a completely different kettle of fish, and this is the problem that many of our critically ill patients have. This is a generalized response where energy and substrate are mobilized to support inflammation, immune function, tissue repair. It occurs at the expense of the lean body mass. People with stress hypermetabolism lose weight and lose body mass faster than do patients who are starving and at bed rest. It can occur in response to a variety of stimuli. We always think, well, this is a surgeon up here talking, and of course he sees things like sepsis, trauma, and burns. But this occurs with pancreatitis, with ARDS, after a complicated bone marrow transplant. At any rate, this stress hypermetabolism is usually associated with some degree of perfusion deficit or shock and resultant microcirculatory injury, and I'll explain that relationship here in a minute or two. When we think of stress hypermetabolism, what this really is sort of the metabolic response that goes along with SIRS, or the systemic inflammatory response syndrome. We're all familiar with this. These patients have increased oxygen consumption, and in order to support that, have increased cardiac index and increased minute ventilation. Laboratory-wise, we see hyperglycemia, elevated lactate, and importantly, increased urinary nitrogen excretion. The respiratory quotient in these patients is in the range of 0.8 to 0.85, reflecting utilization of a mixed fuel source. Remember, the starving patient uses fat as their fuel source. These patients have a mixed fuel source. Yeah, in the stressed patient, carbohydrate metabolism is characterized probably first and foremost by hyperglycemia. Now, for years we've all learned that this has to do with insulin resistance, and in fact there is decreased insulin-mediated glucose uptake. The bigger problem, though, seems to be that there's increased gluconeogenesis that's poorly suppressed by glucose infusion or by insulin. In fact, these patients, even though they are, quote, insulin resistant, in fact have increased glucose oxidation. That's due to increased non-insulin mediated glucose uptake. This particularly is involved in inflammatory cells, things related to the acute phase response. One important thing to note, because it has to do with how much we feed these people, is that the maximum rate of glucose oxidation is 5 milligrams per kilogram per minute. That's been worked out in several laboratories. Fat metabolism is characterized by increased oxidation of all chain lengths. These patients do develop decreased essential fatty acids in the plasma, and this is in part due to hyperinsulinemia, which related to the high glucose, which in turn suppresses fat mobilization. People usually don't progress to ketonemia, although with progression to multiple organ failure, sometimes you see triglyceride clearance decreasing. The lab starts to call you and say that your morning labs are all buggered up because there's fat floating in the test tubes that were sent down. Protein metabolism in these patients is characterized by increased protein synthesis, but also by increased protein breakdown or catabolism. The net effect being an increase in protein catabolism. There's increased muscle release and decreased uptake of amino acids. In other words, there's a net flux of amino acids out of the skeletal muscle. This results in that rapid decrease in lean body mass that I described. Interestingly, there's also a decreased albumin and transferrin synthesis. And of course, as protein is metabolized, there's increased ureagenesis and increased urinary nitrogen losses. So the question is then, is what becomes of all these amino acids that are leaving the skeletal muscle? Well, several things. Some of them can be directly burned as a fuel source. The branched-chain amino acids leucine, isoleucine, and valine can all be oxidized. Some of the amino acids are distributed from the skeletal muscle to the viscera to maintain organ function, to the wounds for wound healing, and of course to the white cell mass for clonal expansion and fighting off the infecting or injurious agent. Some of these amino acids are used for gluconeogenic substrate. As we've already mentioned, these people continue to synthesize glucose, whether they need it or not. And finally, for the hepatic synthesis of acute phase reactants. So the bottom line here is that the skeletal muscle then becomes the substrate for these processes of inflammation and tissue repair. I've put on one slide here. I mentioned earlier that shock and microcirculatory injury were related to this response. This is regulated at several different hormonal levels. Insulin, obviously, is the primary anabolic and storage hormone. It's responsible not only for glucose uptake and metabolism, but for amino acid uptake, protein synthesis, and for lipogenesis. The insulin counter-regulatory hormones, if you will, cortisol and glucagon, as well as catecholamines, stimulate gluconeogenesis, which in turn requires protein breakdown to support it, glycogenolysis, and lipolysis. As I mentioned, this control of this hypermetabolic state occurs at several different levels, including the paracrine level. As you're all aware, there are hundreds of inflammatory mediators that have been causally associated with the systemic inflammatory response syndrome. I've listed just some common ones here that you'll all recognize. And the key thing is that these are all initially released from macrophages and from injured vascular endothelium as a result of this shock that I previously mentioned. At any rate, tumor necrosis factor causes stress protein catabolism. It causes increased energy expenditure even in resting human volunteers. It inhibits lipoprotein lipase and thus prevents the storage of fat. Interleukin-1 stimulates ACTH, and that creates a hormonal milieu that then favors both glycogenolysis and gluconeogenesis. Interleukin-2 causes lipolysis. Platelet activating factor causes gluconeogenesis. So the point is this stress hypermetabolic response that I've been describing to you is not driven by lack of nutrients, but rather by this hormonal inflammatory response to injury that is going on. This is just a summary of everything I've just said, comparing starvation to stress hypermetabolism. And the key difference is energy expenditure actually decreased in the starved patient but increased in the hypermetabolic patient. Respiratory quotient, very low in the starved patient, suggesting utilization of fat as the primary fuel source, but high in the hypermetabolic patient, suggesting utilization of a mixed fuel source. In the hypermetabolic patient, there's a lot of gluconeogenesis, proteolysis, but also protein synthesis and finally ureagenesis going on. Perhaps the most important thing on the slide is this response to feeding. The starved patient, you feed them, the response goes away. It's that simple. In the hypermetabolic patient, what you have to do is stabilize the fractures, graft the burns, treat the sepsis, because this malnutrition response isn't being driven by lack of nutrients, but rather by the inflammatory response. So how do we nourish these people? Well, who should get nutrition support? Well, I think most of us have a pretty good sense of this. Obviously, malnourished patients. How does one describe a malnourished patient? As you know, there are all kinds of indices, of laboratory tests, of anthropometric measurements that can be determined. But in fact, a good clinician with a little history and physical can usually eyeball a patient and tell whether they're moderately or severely or well nourished. So malnourished patients should receive nutrition support. Patients in whom malnutrition is likely to occur, and you all recognize those. When somebody gets run over by a bus and comes to your ICU, in the first 5 minutes that you've met the patient, you know that guy's not going to be eating for a while. He's going to be going to the operating room. He's going to be on a ventilator. He's going to be receiving antibiotics. And it's going to be weeks before he's sitting up and eating. That person needs nutrition support. And then obviously any patient who hasn't eaten for 7 days. When should we start nutrition support? Well, a couple of general rules. We should start it as soon as the need is recognized, and that may be within a day or two of admission. Generally, we like to see the patient be hemodynamically stable, and the reason for that is when patients are receiving vasoactive drugs, particularly vasopressors, gut function and the gut's ability to absorb nutrients may be altered. So we like to see the patients hemodynamically stable, but always within 7 days. Lastly, there's probably no benefit in previously healthy patients who are expected to eat within 7 days. So in other words, if you admit a patient to the ICU and they're going to be discharged tomorrow or the next day, there's probably no reason to start feeding those patients. What can we do when we provide nutrition support? This is something that's evolved over the years. I can remember 20 years ago when the goal of nutrition support was to maintain body weight. And it was thought that you were being successful if the patient maintained their body weight through a long hospitalization. Of course, we know now that if a patient maintains their body weight through a long critical illness, it's mostly going to be fat and water weight as opposed to lean muscle mass. So what can and we cannot do when we provide nutrition support? Well, of course, we can minimize the starvation effects. we can prevent specific nutrient deficiencies, electrolytes, trace elements, etc. And we may be able to modulate to some extent, this has been shown in the pediatric literature, the metabolic processes of the disease. In other words, we may be able to slow this protein loss a little bit, but the bottom line is that we can't abolish the ongoing protein breakdown and wasting of the lean body mass that's associated with catabolic illness. These people are going to lose weight, period. So how much nutrition do we provide? I'm going to describe some of the individual components here. First, calories. There are a number of different ways and a number of different formulae that have been used to predict the amount of calories that specific patients need. In fact, last time I reviewed the literature, more than 200 different formulae are out there suggesting how you should be able to feed your patients. This tells me that probably none of those predictive formulae are all that good. But at any rate, the classic formula is the Harris-Benedict equation, which guesstimates basal energy expenditure based on age, height, weight, and sex. You then multiply that times a stress factor of 1.2 to 2. How do you know what stress factor to use? Well, you really don't. Most of us, going about our daily activities, use about 1.2 times our basal energy expenditure. On the other hand, a person with a 50% burn, for example, they're probably the most hypermetabolic patients there are, may need about 2 times their basal energy expenditure. Another way to determine a caloric need is to use expired gas analysis or indirect calorimetry. Obviously, you don't have to add stress or activity factors here because you're actually measuring what the patient is consuming. Why do we worry about this? Well, excess calories, of course, cause hyperglycemia with its attendant problems. Excess CO2 production and ventilator dependence can also cause lipogenesis and hepatic steatosis or fatty liver. A good starting place, and this is what's recommended by the American Society of Parenteral and Enteral Nutrition, is about 25 to 30 kilocalories per kilo per day in a critically ill patient. I put the asterisk there to remind myself to tell you that if you have a chemically paralyzed patient, and although that's maybe not common too much these days,